Hello everyone, I am Dr. Mythri Shankar, Associate Professor in Nephrology from Institute of Nephrology, Bengaluru, India. I want to share the Indian perspective on advancing equity in nephrology from student mentorship to patient care. 3 years ago, I saw a patient named Ramesh, a farmer from rural Karnataka. He missed 3 consecutive dialysis sessions, not because he didn't care about his kidneys. He was terrified about kidney failure, but because he was unable to reach the dialysis center on time. His dialysis center was 45 kilometers away. One monsoon, one road flooded, two broken down buses, and a harvest he couldn't leave unattended. A village postal code, a monsoon season, the weight of agricultural debt. These became the filters that determined whether Ramesh lived or died. That moment changed how I practice nephrology because I realized in nephrology, the kidneys may filter blood, but equity filters opportunity. India faces a silent epidemic. 1 in every 7 to 8 Indians lives with chronic kidney disease. That's roughly 12 to 15% of our population, which is over 150 million people. But here's what haunts me. Most don't know about it. In rural India, CKD prevalence rises even higher, up to 30% in some regions, nearly 3 times the urban rate. A young farmer in Andhra Pradesh has a 30% chance of kidney disease, while an urban professional in Bengaluru has roughly 10%. Why? Because rural populations face hazardous occupational exposures, lower access to clean water, pesticide and heavy metal contamination, and often they are discovered too late when dialysis is the only option left. And what about diabetes and hypertension? They drive over 40 to 60% of our CKD burden. With 101 million Indians living with diabetes and 315 million with hypertension, our nephrology workforce faces an impossible tsunami. But here is what devastates me most. Only 10% of India's end-stage kidney disease patients receive any kind of kidney replacement therapy. Out-of-pocket costs consume over 60% of household health spending for low-income families. So patients choose between feeding their children and filtering their blood. Yet, even as we face this burden, another quiet crisis unfolds in our classrooms and departments. Women now make up over 51% of medical students nationwide. In some states like Kerala, that number reaches 82%. Yet, in nephrology research authorship, women remain just 17% of first authors. In clinical trial leadership, the representation is even smaller. Women in Nephrology India launched only in 2021 and already has over 300 female nephrologists in its network. This is progress, yes, but it underscores a fundamental truth. Mentorship gaps don't just exist, they perpetuate inequity for generations. Evidence shows that 72% of medical trainees report that mentorship is the single most impactful element of their training. Quality mentorship increases sense of belonging, builds disciplinary identity, and substantially improves persistence, especially for trainees from underrepresented backgrounds. But for too many Indian medical students, especially those from rural or underprivileged communities, that mentor never arrives. So how do we build that mentor? Let me share a story. One of our residents came from a village outside Davangere, where her grandmother dialyzed without ever seeing a female nephrologist. Her parents were teachers in a government school with no connections to medical academia. But one senior mentor took her to clinic, asked her real questions about her barriers, celebrated her idea, and most crucially, saw her. Today, she runs a successful hospital in rural North Karnataka. Last year, she identified over 100 people with undiagnosed chronic kidney disease, and she has inspired 3 medical students from her own village, students who will shape the nephrology in the future. That's what intentional mentorship does. It doesn't just build specialists, it builds change makers who remember where they came from. But mentorship alone cannot solve a problem rooted in poverty, geography, and systemic inequality. We must address the social determinants that determine the kidney fate. In rural India, that means reliable access to dialysis centers. It means transportation systems that don't force patients to choose between harvest and hemodialysis. It means subsidized treatment for families already spending 60% of their income on healthcare. We don't just manage kidneys, we manage the conditions that shape a life. That means building teams. Nephrologists, yes, but also social workers who understand Indians' informal economy. Community health workers who live in villages we serve. Patient partners who have navigated the gaps themselves. When we design programs, we ask, does this patient have reliable transportation? Can they afford the medications? Do they understand their disease in their own language? So here's my challenge to each of you as emerging leaders in Indian nephrology. Tomorrow, when you're with a medical student, a resident, or a patient, ask yourself one simple question. What does equity look like in this moment? Is there a trainee from a rural background who needs you to see their potential? Is there a patient whose barriers you've overlooked because you've never lived them? Is there a voice not heard in your department? And then choose the action that brings equity closer. One mentorship, one patient conversation, one system change. One moment at a time, we can reshape what nephrology looks like in India. I chose nephrology because I saw how much a postal code could dictate kidney outcomes. I stayed because I believe we can be different. We can build a specialty where every rural medical student sees themselves, where every farmer in Karnataka gets the same dignified care as a CEO in Bengaluru, where mentorship flows from those who have power to those climbing the ladder behind them. That's not idealism. That's our responsibility as Indian nephrologists. Thank you.